What I'm going to be talking about for the next 20, 25 minutes or so, just to be clear, you're in for a real treat today. This is Sisyphus. This is not syphilis, in case you were sure. I'm not going to be talking about syphilis, well, not if I can help it. This is going to touch on classics, philosophy, all sorts of things that we don't normally get a chance to cover in this meeting. And I'm going to take a rather jaundiced look at the way the NHS works, which I hope won't come back and bite me at some point in what remains of my career, but tell you how building national services works or doesn't work within the context of the way the NHS is structured. So a few disclosures before we start. Again, this is what's now known as Manhattan. This is the centre of Manchester, which is rising upwards at a very considerable rate. Some disclosures. At present, I'm a consultant surgeon at what is now called, for better or worse, Northern Care Alliance. They used to be called Salford Royal, and before that, Hope Hospital. I give expert advice, medico-legally, to courts in the United Kingdom and the Republic of Ireland, and I'm not paid. I am paid for doing that. I have a number of other unpaid roles. I'm advisor on sepsis to the Royal College of Surgeons of England and Edinburgh. I'm not paid for that. I'm not paid for the advice I give as a colorectal advisor to NICE, or to the NHS England Acute Deterioration Board, which was dissolved in 2024. That led to the implementation of Martha's Rule. Some of you will have heard of that. I have no conflict of interest related to any pharmaceutical products that we're talking about here today. So Sisyphus, this is the introduction to classics. Why is Sisyphus important in what we're talking about? Sisyphus was the king of Ephyra in classical Greek literature. That's now known as Corinth. Sisyphus was a very clever man. He was extremely cunning. He revealed Zeus's abduction of Aegina, which Zeus did not like at all. And Zeus repeatedly tried to have Sisyphus killed by all sorts of interesting and kind of classical and rather gory means. But Sisyphus managed to avoid repeatedly. In fact, he did away with most of his competitors in order to become king of Ephyra. And repeatedly cheating death, he then died of old age. And that's where Zeus got him. Because once he was dead, Zeus cursed him. And the curse of Sisyphus was he would spend eternity rolling this boulder to the very top of a hill, and just before he got to the top of the hill, he would lose control of it, and the boulder would run all the way back down to the top of the hill, and then he'd have to start the whole thing all over again. That was the curse of Sisyphus. So tasks which are now referred to as Sisyphean are both laborious and, most importantly, completely pointless and futile. They're interminable. They go on forever. And Sisyphean has become a way of describing a paradigm of something which is completely absurd. Not everybody has seen it that way. Albert Camus, this is the philosophy bit. Albert Camus actually wrote a book in 1942 called The Myth of Sisyphus. Albert Camus, as a French philosopher, said he thought that what happened to Sisyphus embodied the struggle towards the heights, which was actually enriching and enough to fill a man's heart. And one must imagine Sisyphus happy. Well, I think that tells us personally more about Albert Camus than it does about anything else, because I don't see how that could make anybody happy. And what I'm going to describe over the next 20 minutes or so certainly didn't make us happy. So I'm going to talk about how we went about establishing a national service for intestinal failure. And to do that, I need to remind you a little bit about what intestinal failure, or IF, is, why a decision was made to establish a national network, what happened when there were attempts made to do it, and who was involved. I'm not going to name names for obvious reasons. Why did it take more than 10 years to restructure clinical services to meet the needs of our patients and actually do anything useful? Who was responsible for that? Not in name, but in role, and whether or not it was actually worth it. So, intestinal failure, and I've lectured, in fact I gave a Brian Brook lecture here on intestinal failure many years ago, is that when you lose gut mass below the minimum amount you need for adequately digesting and absorbing nutrients and fluid and electrolytes, and that's Jeremy Nightingale's definition from St. Mark's in 2001. But the key thing is, if you have intestinal failure, you cannot live unless you're either getting intravenous feeding or at least intravenous fluid therapy on a regular basis. Without that, you become dehydrated and die, or you become malnourished and die, or possibly both. And there are three types of intestinal failure. There's acute intestinal failure, and many people in this room, knowingly or unknowingly, will have had a bit of acute intestinal failure. You've had an operation, there's been a problem, your guts haven't got going properly, you've had to have a little bit of intravenous feeding for a few days. Those are things surgeons usually manage. And then there's chronic intestinal failure, sometimes called short bowel syndrome. Those patients normally are on intravenous feeding at home, quite often for the rest of their life, so-called home parenteral nutrition. So how did the origins of a service providing care for patients with intestinal failure come about? And there are three names that are important here. There is John Rhodes, who is a Quaker surgeon. There is, and that's important, I'll explain that in a minute, there's Stan Dudrick and there's Doug Wilmore. And I had the honour of actually meeting two of these people, actually worked with Doug Wilmore for a little bit. Doug, and I think Doug's still alive, but he's now retired to Hawaii. He was professor of surgery at Harvard, although he did this work originally in Philadelphia. But the driving force was John Rhodes. John Rhodes, I had the honour of meeting in 2001 when he was on his deathbed, actually, and he was a surgeon in Philadelphia who came up with the concept of intravenous feeding. I have to tell you, for the people who are squeamish about animal experimentation in this room, this development happened using fairly extensively beagle puppies, and what they were able to demonstrate was they could keep beagle puppies alive, and they developed into adult dogs once they were able to perfect getting into their veins so they could deliver food, intravenous food, in a sterile manner in their veins. And that led to parenteral nutrition, which here now is delivered in these great big bags that we connect to our patients and cannulate their veins to deliver it. And that development happened in about 1968 in Philadelphia. John Rhodes was professor of surgery in Philadelphia. And ironically, when I saw him in 2001 on his deathbed, he was 94 years old. He was dying of advanced gastric cancer. He couldn't eat because his stomach was blocked up because of gastric cancer. And he was on intravenous feeding. And they were feeding him until the end of the year to keep him alive for tax purposes. Because in America, if he didn't survive past December the 31st, it had all sorts of implications for your will and probate. So they kept him alive with intravenous feeding, and he passed away early the following year. He was a remarkable, remarkable man, and a man of great Christian faith. But very early on, in the late 1970s, Miles Irving, who some of you will know, who again is a previous Brian Brook lecturer here, and John Ellard Jones, also a previous Brian Brook lecturer here, from Salford. Miles was my mentor, and you heard a Brian Brook lecture last year from, remarkably, Miles's son, Peter Irving, who's professor of gastroenterology now in London. They were visionaries in this country and thought there's something in this, and we're going to need this for their patients, because their patients were dying of malnutrition, because we could sort out their Crohn's, for example, but they lost a lot of bowel, and they would then die over the following year because we had no means of keeping them alive until TPN came along. They saw this, they went over and they spent time, particularly with John Rhodes, learning about intravenous feeding. They brought the technology back to the UK, and in the late 1970s, just before I left grammar school, actually, two national units were established. One here in Salford, and one here in London at St. Mark's. And that's how it all began. That's how the whole process began. So, why was thought given to commissioning this nationally? Well, prior to 2007, we just had these 2 units. And what we began to see developing was a postcode lottery, particularly for home parenteral nutrition. What we found was patients who lived near Salford or patients who live near St. Mark's were much more likely to get TPN, possibly because doctors in the surrounding hospitals didn't even know it existed, or if they knew it existed, thought there's something very esoteric and I'm not getting involved in that. And unfortunately, their patients were not offered that treatment. The result of that was even people who did know about it and referred their patients in, patients had very long waits for transfer to those 2 centres because those were the only 2 places offering it. And actually, we began to find that patients who were waiting to go to these 2 centres were much more likely to die than once they were there. So there were big problems as a result of this. And as a consequence of this, we began to see noise from specialist associations like the Association of Parenteral and Enteral Nutrition, so-called BAPEN. It's another association that involves patients and looks after the nutritional needs of patients. And the next thing I have to tell you sounds remarkable, but I promise you, as far as I'm aware, it's true. There was a lot of hubbub, but nothing was done until there was a conversation, and I know this sounds like part of the plot of Bridge of Spies. There was a conversation between somebody senior in NHS England and a medical gastroenterologist in London in a gents' toilets. And a decision was made that we must do something about this. There's too much noise. But they instructed a medical gastroenterologist in London, but not one at St. Mark's, who had all that expertise, to sort it out. And that medical gastroenterologist decided, yeah, I'm going to sort this out. But actually, he didn't involve surgeons. Nevertheless, decided to sort the whole thing out, not just intravenous feeding at home, but acute care that involved intravenous feeding in hospital. So that was a rather shaky start, you might argue, which led to the production of this document in 2008, the Strategic Framework for Intestinal Failure, produced by that individual and NHS England and taken through Royal Colleges. So that was the first attempt to establish a national network to provide treatment for patients with intestinal failure. It was aimed to address home parenteral nutrition because that was the problem at that time. But there were no data. We didn't know how many patients were on home parenteral nutrition. We had no mechanism for even collecting that data. And we certainly had no idea how many patients were in hospital. This document came up with all kind of complex levels of care, which caused huge confusion. It even didn't define surgery for intestinal failure, though it talked about it. It didn't define the training needed for surgeons providing that care or the resources that were going to be needed. There were no clinical standards. Nobody said what the minimum standards of care were in this document. There was no thought given at all to how much it would cost to do this. And actually, the specialist organisations who looked at this, including one that I sat on, said, well, this is rubbish. It's completely unworkable. It's pie in the sky. Thank you very much. It's not going to happen. And it was discarded in about 2012 after it had rattled around for 3 or 4 years. And we have no idea how much that process cost. Nobody ever recorded the cost of producing the document, the man-hours that went into it. But what it did do, it led to this document in 2010, which was a proper attempt to at least define what the surgery was, what the standards were, what volume of these cases you should be doing if you want to do it, what good care should look like. That was led surgically by the professional bodies, which was actually the Association of Surgeons, and I was very honoured to chair that process. There was a big team, there were about 10 of us who produced that document, and that led to a further attempt to commission a network. There were peer reviews. There were 32 site visits by trained teams that went out, each of them supported by a commissioner. That's someone, if you like, an NHS manager who's responsible ultimately for commissioning the care. There was a surgeon, a physician, a nurse, a pharmacist, or a dietitian. Sometimes we only had one or the other. And a report was produced for every single visit that was made to every single centre that said, yeah, we want to be a centre providing this care. And the report was produced by a commissioner, and ultimately the aim was that report would be agreed by the commissioner and the clinicians. But there were problems. NHS England decided they wouldn't ask the 2 national centres to be part of that process. They just assumed they would do it and their care would be fine. And the other centres said, whoa, hang on a minute. Why are you asking us to do this when you're not asking the 2 centres? You just assume they're okay. That's not fair. That's not a level playing field. Most of the centres actually provided either no data or certainly very little data. One centre produced a return that I've said was dodgy. Actually, it was frankly fraudulent, saying they were doing things they clearly weren't doing simply because they thought they would get a big national service and a load of cash. There were disagreements with commissioners as to the quality of the service. There were geography and political issues, so commissioners said, yeah, well, we need a centre down there because, you know, there isn't anything there, even though there was no expertise there, which didn't work, and there was no kind of opportunity or thought about how a centre could be developed there and how that would work, what the mentoring and support would work. And ultimately, and this is the best bit, and I promise you this is true, the responsible commissioner left, and he lost the data from those 32 visits. He had it locked in his garage, and he lost the key. And he said, I'm sorry, but you can't have the data. And in fact, I ended up talking to somebody in the House of Lords about, you know, threatening, if you don't get into the garage and get the data, there are going to be questions asked in the House of Lords about why you've done this. Again, the whole process wasn't costed, and we don't know how much that exercise cost. But I can tell you there were a number of us visiting centres all around the United Kingdom, staying in hotels, not, you know, 5-star hotels, things like this place, having dinner, having breakfast, visiting a centre the next day, and then going on to the next centre. It probably cost around £200,000 of taxpayers' money and led to diddly squat, frankly, as an outcome. So that's 2. There was a lack of commissioning and administrative support. As I said, the data were incomplete and misleading, and then by the time we got to them, they were out of date. There was no clear thought about how many units were needed. And then, as part of that process, this individual hoved into view. I don't know who you remember who this is. This is Lord Lansley. There were changes to the commissioning arrangements. All of a sudden, units had to compete with each other because of the construction of a healthcare market enshrined in these Lansley reforms, a process which Ara Darzi referred to last year in his overview as calamitous. And Ara's, you know, I know Ara very well. He's a very smooth political operator. I'm sure he wouldn't mind me saying that. So for him to say this was calamitous gives you an idea of how badly the Lansley reforms affected healthcare. And of course, what people hadn't appreciated, some of these 32 units actually put in joint bids. They said, well, this place can do the home care, this place can do the acute hospital care. They had to be thrown out because you couldn't have a joint bid because of the Lansley reforms. People were supposed to be competing with each other. So the outcome of that was there was an attempt to scrap the process again in late 2016. The NHS decided the numbers of patients were too small. Actually, they were about 90% of what we'd predicted. They reflected only the units that bid as well, so we had no idea how many patients there were outside those units. There was concerns that the bid process had been mismanaged. One centre appealed, that they said that their bid hadn't been considered properly. No one had thought, well, what do you do with an appeal? There was no process thought through as to how you would address an appeal. The senior leader within NHS England responsible for specialised commissioning, whose remit this fell under, was then suspended on an entirely unrelated issue and eventually struck off the medical register. And I won't tell you any more about that. Let's just say it was not a medical issue, it was a behaviour and a probity issue. The patient group, PINT, who, if you like, are the equivalent of the Ileostomy Association for patients on intravenous feeding, had had enough at this point. They really did go like this. I was sat at the meeting where they said, we're not leaving this room until you agree you are going to establish a national network that meets the needs of our patients. And again, we had to threaten to ask questions in the House of Lords unless this moved forward. And it really was, at this point, Fred Carnot's. However, in 2018, the issue came under the auspices of the Colorectal Clinical Reference Group at NHS England. And for once, there was a dedicated management team. A service specification was published. I was, again, fortunate to be asked to be involved in that, although I have to say by now I was getting pretty fed up with the whole process, and I did start to feel like Sisyphus. We had a desktop exercise with standardised questions mirroring the ones that were still locked in someone's garage. The replies were validated and marked. It was a huge paper exercise which took months. And again, some centres provided little or no data. Some of the data was probably flawed. There was little clinician involvement in submission of the bids. We had managers doing most of the paperwork, and what they said was often not right, not because they were trying to be crooked, but they just didn't understand what they were being asked in some cases. And many of the bids were clearly poor, and they didn't match the published specification. But eventually we got to a consensus and started to commission dedicated intestinal failure surgery. We established 12 centres. Still hasn't been fully costed, but we then had commissioning guidance that we were able to start using that involved competitive bidding between centres, because that was still required at that time, and the establishment of a national network with a defined budget, a management team. The shape and scope of the proposed network had been set out and discussed with public consultations, standards, and there was a competitive procurement process with legal oversight managed by this commissioning support unit, who at the time were managing these kind of competitive bids. And we now have at least 12, shortly 15 centres providing this care, some of them in acute settings for people who are ill and need to be in hospital, and about 30 centres at home providing home care linked to that. There are 2 national reference centres supporting the development of these around the country, one at St Mark's and one in Salford at the moment, and unified reporting arrangements linked to funding. So there is a process for actually measuring the cost of care and making sure that the taxpayer is getting value for money, and we know that care provided is of good quality, but it's still not fully costed. So we eventually got a national network meeting our patients' needs. It was at least peer-reviewed when it was set up. Patients are able to access care closer to their home. Waiting times have come down massively, actually, because we have more centres providing care, and there are defined published standards that centres have to stick to. We hope those will lead to better outcomes. We hope it will be more cost effective for the taxpayer, but we don't have tariffs because they haven't been set, so we still don't know. But the potential for development is there. It will probably take years, and I think it has been Sisyphean, extremely divisive, and God knows how much money has been wasted to get to this point. Now, some of you will know that very recently an announcement's made that NHS England is going to be scrapped. It's been referred to as the biggest quango in the world, and the Department of Health is actually taking over from NHS England. I thought it was interesting that Jeremy Hunt is cautiously optimistic. He was actually in charge through most of this process, despite the concerns about NHS England. So there we go. So in summary, huge amount of work put in to support NHS England in lengthy and complex commissioning process. It's been frustrating and divisive. I think it probably has been unnecessarily expensive and prolonged. It was made much more difficult by the Lansley reforms, which were introduced in 2012, which set hospitals competing with each other when they needed to be collaborating. And I have to say, I don't think we'd have got to this point at all had it not been for patient pressure. And I think at many points along the road, healthcare politics got in the way of providing good care. So the question is, will future changes improve planning for patient services if Department of Health is going to be in the driving seat? I'm not sure, actually, because the key functions are still going to be the same. We're still going to need people to lead it. Whether they work for NHS England or the Department of Health doesn't change. We still need doctors involved. We still need patients at the key to change services to meet patient needs, and we need better communication. We need managers and commissioners and legal advice, and most importantly, we need data to inform us in terms of what we should be doing. Would it have been easier or more or less efficient or more or less divisive if Department of Health had been involved? I don't think we know. For those of you who are not sure, this is an elephant giving birth. And I think that's a fitting way to end this talk, because I certainly feel at the end of this process, that's what it felt like we were involved in. I think we now do have a baby elephant. Whether or not we can get that elephant to the size we need to and to do what it needs to do, I don't think we can say. But it's been a difficult Sisyphean process. I think some of us have emerged possibly better human beings, and certainly more patient human beings as a result of it. But it's certainly something that's dominated the last 10 or 15 years of my life, and something I personally wouldn't wish to repeat. But thank you for your attention. So I think I brought us back pretty much to time, in fact. I will take a couple of questions, though, if there are any burning questions before I introduce Natasha. There are no burning questions. There's one I was going to say, everybody's already seen an elephant give birth before, which I have to say, it took me a while to find that slide, I must tell you. I think my wife became very suspicious of my internet search activity. So there's a question at the back.
Yeah. Hi, Sarah Minto, West Yorkshire IA. Really fascinating presentation. I didn't realise probably in 1994 in Booth Hall Hospital how lucky I was that I was actually in the Manchester area to get TPN.
Booth
Hall.
Boot Hill Hospital. No, it used to be known as Boot Hill.
Oh, did it?
That's right, yes, I did.
Just wondering though, how have you got plans to feed back some of obviously the very interesting journey that you've had? How can this not happen again, or how can NHS England, as they take, Department of Health as they take it over, how can we feed some of these things back to them?
Well, the short answer to your question, actually, is I met yesterday afternoon with Sir Norman Williams and individuals at the Department of Health and Social Care, specifically to discuss commissioning arrangements for specialised services. And these issues were fed back very clearly. The problem one finds, in my experience, and I didn't perhaps make as much of this as I might have done in this talk, is that you are endlessly, in dealing with these organisations, dealing with an organisation in a state of flux. So what you find is you spend 3 or 4 months explaining what intestinal failure is, what TPN is, what patients with these problems need, what are important to them, and not just us as clinicians, but our patients do too. And then you find the individual you spent the last 3 or 4 months talking to has been moved to a different job, and somebody else has just come in who's desperately keen, but doesn't understand anything about it. And the problem is this going to change with the proposed changes that are coming in this year? In relation to the NHS 10-year plan? Are we going to see more stability? I think the answer is no. We're going to see less stability because there's going to be, I don't know if you know this, but if you look at the Darcy report, and I spent a lot of time reading it, we have a £37 billion shortfall in capital budgets in the NHS. That hospitals are falling down. Our own hospital hasn't invested in any money in sewerage and drainage, so they had a sewage leak which ruined a CT scanner, which has now had to be thrown away, and a new CT scanner bought at the cost of over £1 million because they weren't actually spending money on fixing the pipes. So I think, part of the problem is, do I think things are going to change in the way services are commissioned? Not necessarily. I'm not optimistic they're going to change because I think the command and control structure is too complicated. And as I said earlier, is it likely that the people who have been involved in NHS England aren't going to be the same or similar people who are now doing it. They're just going to be playing for a different team, I think, basically, with Department of Health on their shirts rather than NHS England. So, watch this space. I don't know. So I'm sorry I can't give you a very positive outlook because I'm not terribly positive about it. Please. I think if you don't mind, we'll make this the last question because I'm very keen to get Natasha up here talking to you.
Hi, Jim, Birmingham IA, St Mark's patient, and I had no clue that other hospitals didn't have IFUs previously. My question is, it's related to the first one, but you mentioned that patient pressure helped resolve the issue.
Yeah.
Could there be more use of social media to illuminate the message that you have here? For example, putting this lecture on YouTube, for example, or,
I'm
exhibits.
very anxious about social media, and I'll tell you why I'm anxious about social. I think social media is a two-edged sword, and I think it is literally a jungle. What you will find is the message, managing the message, even if the message is reasonable and sensible, becomes impossible. And what you see, and you see this already, somebody puts a perfectly reasonable and sensible statement out on social media, and the next thing you know, it's all over social media and it's been spun. People say different things. You get a kind of Trumpian kind of thing where the message is altered to suit individuals, people. I've seen it actually, never mind social media, in mainstream media. I gave a lecture in Edinburgh a few years ago, which the Daily Mail got hold of, and it was plastered all over the Daily Mail. Hundreds of patients in the United Kingdom die a harrowing death every year because of the absence of intestinal failure. That's not what I said. What I said was patients need treatment for intestinal failure, and that is best provided in specialised centres. And without that care, a death from intestinal failure can be horrible and harrowing. That all of a sudden because that doesn't sell newspapers. So no, I'm not sure that I think the patient pressure that needs to be brought to bear on the people that we fund as taxpayers to provide the care that we need, the patient pressure should now be integrated within healthcare planning by the independent commissioning boards, the ICBs, which is how healthcare is delivered these days, which are now statutorily required since 2022 to meet the needs of their local population. That's where local pressure, that local populations tell the ICBs what care they want. And then the ICBs are required statutorily, not to say, yeah, very good, go away, but actually to make sure that happens. So I think that's the solution to that problem. The patient voice needs to be heard much more clearly, and hopefully the recommendations and the structures we now have in place will permit that.